Good evening, and thank you for joining us on another edition of Wango Spaces. It's been a hot week, to say the least, transitioning from NHIF to SHIF. So it's very important to have this kind of timely discussion around the mechanics of SHIF so that you can know the implications. We'll get started with Tracy. Dr. Tracy, maybe you can introduce yourself a little bit for those who don't know you and what you do.
Okay, thank you very much. My name is Tracy John. I work with the Ministry of Health. I'm the acting head of health financing at the ministry.
Could you tell us a bit about your background?
All right, my background, I am a medical doctor. I did train in medicine, bachelor's of medicine and surgery. I also did pursue a master's degree. Master's in neurosurgery. I've also studied a master's in business administration as well as international healthcare management and majored in health financing. Additionally, I've also done a couple of trainings here and there in some courses in health systems management and leadership and governance.
Brian, over to you now. Maybe you could introduce yourself, what you do, and a bit about your background.
Thank you, Eric. My name is Dr. Brian Lishenga. I'm a medical doctor by training. Studied at the University of Nairobi for my undergraduate. I did my postgraduate in medical physiology and later a postgraduate in family medicine. I have been a lecturer at Egerton University for quite a number of years, about 15 years. For the last 5 years, I have been the chairperson of the Rural and Urban Private Hospital Association of Kenya, which is a non-political association that brings together almost 420 healthcare facilities of different sizes and different specialties. Private sector facilities, initially focusing on private sector facilities in rural areas, which was our initial membership. But as the country is changing, a lot of what were rural areas a few years ago are now becoming rapidly urbanized. So since last year, the association also rebranded. It is now the Rural and Urban Private Hospital Association. We have membership all over Kenya, and it is my pleasure to be on this space to share some thoughts. Thank you for inviting me.
Thank you so much, Dr. Brian. We'll be back to you in a few. So perhaps you can start with Tracy. You can tell us a bit about the background of NHIF and how we have now transitioned to SHIF. What was wrong with NHIF that we needed SHIF?
Thank you very much. I will talk about the principles behind the change and not so much of directly in relation to what is wrong, what is right, because it's a complex matter. However, the mandate for health financing, as far as the health systems and the health service delivery in the country is concerned, is to make sure that we have adequate financial resources so that we can have enough to put into the other resources that are required to run the health services. And that is in terms of the building block, the inputs of the health systems, including the human resource for health, infrastructure and event, looking at the health information system, all these things, including the medicines, that is the health products and technologies, they all require financial resources. So health financing is very key in terms of making sure that the health service delivery is done in the right way. And it's actually one of our goal of trying to get towards universal health coverage, which is basically trying to provide and making sure that all Kenyan people are provided with the services they need, being of high quality, affordable, as well as making sure they are equitable and people don't experience financial hardship when they seek these services. So that goal of UHC is what the health financing element tries to address. When we come to health financing, also what we're trying to do is to say what are the sources, where do we get enough resources, how do we mobilize resources that are adequate and allocate them properly so that we have enough going around for all the people in the population. And this is where this whole principle of health insurance is anchored, because then we look at the different sources of health financing and we know that we have the four main sources where we have the government sources, we have the health insurance aspect, and we have external funding, commonly what we call the donor funding, as well as what the population pay at the site at the point of service delivery, that is the out-of-pocket expenditure. So looking at those four elements, so the whole principle of health financing is to try and balance those four by making sure we have more of government funding, more of health insurance, and less of out-of-pocket expenditure and less of reliance on donor funding so that we have sustainable financing for the country. Those are the principles under which we are working with, and that's actually what informs the need to strengthen our health insurance source and the need also to strengthen our government sources of health financing.
But how did NHIF work From basic principles, what was it grounded on?
Looking at the health insurance, if we are to zero in on that, the challenges that we were facing that needed to be addressed were quite a number, but looking at the main ones, we wanted to make sure that we have more people coming into the pool of health insurance, because to be able to achieve UHC, we need to have almost about 85% of the population covered with health insurance. Yet at the moment, we only have about 26% of the population covered with health insurance. There are also those elements of the proportions of funding that should come from government and the proportions that we know that we needed also to increase. Other issues under universal health coverage, you want to bring everyone on board, and you want to make sure that people contribute, and we contribute that money or the premiums that we would need to pay in a progressive manner, which means that people pay based on their level of income, so that we're able to pool the resources and pool the risks, so that those who may have more are able to co-subsidize those who may have less. Those who are healthier are able to co-subsidize those who may be more sickly, and the young are able to subsidize the elderly who may require more health services. So looking at those principles, also making sure that the services or the benefits that the people are able to receive are equitable, so that we don't have some people getting better benefits than others or having more access to the benefits than others in the same population. Some of those principles were the areas that we needed to address, and considering when we started NHIF, which is several decades ago, we needed to improve on it to be able to accommodate those principles, and that is what informed the need to reform NHIF.
What's the difference between NHIF and SHIF in terms of basic principles?
Principally, when you look at the way the two institutions are set out as provided by the law, because NHIF was also guided by the law that existed then, and SHA is also informed by the existing law currently. Based on those principles, when you look at the issue of benefit, under SHA we have harmonized benefit packages, which are provided to all the contributors or all the members who are enrolled. That is comparing to, say, the fragmented schemes or different schemes that existed under NHIF that needed to be harmonized for efficiency gains and equitable access to those benefits. The other area that is significantly different is the fact that mainly under NHIF we were operating more like a voluntary contributory method, where the formal sector were contributing because as a statutory deduction, but when it came to the informal sector, which is a bigger sector in our country, contributing about 85%, then this sector was more under voluntary contribution, which meant that probably people would contribute when they felt like they needed the benefits, as opposed to contributing on a regular basis, which meant that the sustainability then became weaker. The other key difference is that under SHA, as we're aware, SHA actually carries 3 funds, whereas NHIF was just 1 fund, the insurance fund, managing the insurance scheme. But under SHA, the authority, that is the Social Health Authority, seeks to manage 3 funds, and that is the Primary Healthcare Fund, the Social Health Insurance Fund, SHIF, and the third fund being the Emergency, Chronic, and Critical Illness Fund. What that does is that it pulls resources from different sources. The middle fund, being SHIF, brings resources from the contributors, the members, that is the insurance part of the fund, while the other 2 funds, they are funded by the government, exchequer funded, which means that now we are pulling even resources from government in a prepaid fashion. So we know how much we need and we put the money there, and we are able to now purchase pieces using those resources that are provided by the government. And that means that the pool of resources becomes much larger and compared to what we had in NHIF, which was mainly the formal sector contribution and the insurance scheme. That said, I think I've probably touched on the major, yes, principally speaking. And I think as the discussion continues, maybe we will unpack whatever else is required at that point in time.
Thank you so much, Tracy, for setting us off. Brian, from the healthcare provider's perspective, how was NHIF structured and what's different with SHIF?
First of all, NHIF was structured as both, a contracting body, it was also an accrediting body, and to some extent also behaved as a regulator. So to the extent that to be onboarded a facility on the NHIF cover would require inspection by NHIF officers to your facility, which of course would be including they would score your facility. Basically, there was a template that the NHIF officers used to follow, and they would give you a score out of 100, really like an examination. And depending on that score, then they could pass you, fail, they could determine that you can come on board or not. And of course, you know that there have been accusations that that system got rigged by those who were able to influence that process. So that was the accreditation part. And then that report would end up the NHIF branch, and then the NHIF board would be required to sit. And then the constitution of the board of NHIF historically did not have provider representation. If you remember that the board was made out of the representation from Kenya Medical Association, that was the closest you have to providers, but not healthcare facilities. And then you had the Federation of Kenya Employers, you had COTU on board, you had NAT on board, and then you had representations from Ministry of Health, I believe, National Treasury, etc. So that board would then, as you can see, of course, by the very structure of the board, representation of the health sector there is minimum. And you can imagine that would be the board deciding which hospital to empanel. And then, of course, that would be now the same NHIF would act as a regulator in the sense that they would be determining what services you can offer, which services you cannot offer, and that sort of a thing. So that is how we were interacting with NHIF. And the other thing is, historically, what we call the tariffs, the packages, were shrouded in a lot of secrecy. So in essence, I'll give you a good example. In fact, one of the things that led to the formation of our association as a predominantly initially presenting rural healthcare facilities, we came to discover, for example, let me take an appendectomy, which for those who are not medics, the surgical removal of the appendix for whatever maybe illness. You would find that NHIF had 3 contracts. So there was what we call contract A, then contract B, and then contract C. Now, contract A is what NHIF would give to government or public facilities. And usually that contract would have very low reimbursement rates for procedures at government facilities. And so the explanation was maybe government facilities are already being funded by the exchequer. They don't have as many overheads and things like that. But essentially the government facilities would get a smaller fraction for every procedure. And then you had contract B, which was for mission hospitals and what they would call low-cost private hospitals. And that turned out to be many private hospitals in mashinani areas where the economic capability of the common ranch is not very high. Depending on where you are, you have to be sensitive to the economic situation. So a lot of faith-based hospitals and a lot of low-cost private hospitals, especially in rural areas or in what you'd call urban underserved areas, would be on contract B. And then that contract B was what they used to call a comprehensive contract. In other words, the facilities on that contract were mandated by NHIF not to co-charge clients. It was essentially a walk-in, walk-out contract. And then contract C, which was what was called for the high-end private hospitals, and the National Referral Hospitals General also used to operate on that one. That contract was a co-charge contract. Now, let me just explain a critical problem with how the NHIF there was structured. The appendectomy I was talking about on contract A for public hospitals, the reimbursement would have been maybe per procedure, say 30,000. That is what the hospital would have gotten per procedure. And then on contract B, you would find that these low-cost private hospitals in rural areas and the faith-based hospitals would be paid a flat rate of 60, but they are bound by contract not to co-charge. And then on contract C, you would find that NHIF would still pay, and these high-end hospitals are mostly in our big towns and big cities, would either pay them that same 60,000 or sometimes even more, even up to 80,000 in many cases. Plus, that hospital would have the option of co-charging in the contract. So what used to happen is this, and what essentially happened, and why I feel like Kenyans have a lot of hangover. We as a people, we have a lot of hangover from how we were let down by this structure. And that's part of the reason why we have to struggle to convince people that SHA might do things better, because we can't believe it. I would explain it this way. Because of these disparities, what used to happen is that if you go to these high-end urban hospitals, all the doctors would be there. And then you go to government hospitals and the doctors are not there. And you come to these faith-based hospitals, maybe the lower-end private hospitals, maybe the doctors are there, but the quality of care is poor. And this was all because of how the money was flowing. Because you see, even doctors, surgeons, whoever, all these people are rational human beings, and a rational human being will follow the money. So if you are paying an appendectomy to one hospital, you are paying 80,000 with the option of copay only for that group of hospitals. That hospital would tell the patient when they walk in, hey, NHIF itakulipia 60,000, but your bill is 200K. Your 140 you have to top up, and that was perfectly legal. And then so the whole bill would come like to 200,000 for the same procedure. With that kind of basket, what would happen is the hospital could easily retain 100,000 to cover its expenses from that procedure, and very easily pay the doctor and the anesthetist to share the other 100,000, and everybody goes home happy. But for the public hospital where they are being paid 30K, of course, you would argue the doctor there is on salary, but what is the incentive? And for the low-cost faith-based hospitals and private hospitals, they have a limited basket of 60,000. So maybe the procedure will be done by a medical officer instead of an obs gynae. And maybe if you wanted a surgeon to do it for you in those hospitals, they would refuse. So eventually what happened is a lot of expert labor has moved from the rural communities, because you'll not find a neurosurgeon in a village somewhere. Why? Money is not available to pay them in those areas. So these are some of the structural problems that we had with NHIF. There are many others. I have talked about NHIF being Baba and Mama. I've talked about the contracts that were all over the place. But a critical problem with NHIF was what we call the moral hazard. The fact that a large chunk of patients would only pay for NHIF when they fell sick. A large chunk of people, they fall sick and then they pay. So what that would mean is that the fund would be constantly operating on a negative. And SHA has made an attempt to cure that, which has been a very painful, bitter pill for Kenyans, because the attempt to cure that is to make it mandatory. Because remember, NHIF was only mandatory for formal sector employers. Everyone else was paying voluntarily. So that created a very, very big problem right there. I hope that helps to set the stage there.
Yes, double click on the issue of fraud within the system. One of the highlights of the movement from NHIF to SHIF has been that there was too much fraud and ghost payments within the system as NHIF was structured. Could you speak a bit about that?
Yes. Now, this is like a 50-50 or issue, depending on who is talking about it. To a certain extent, as a representative of private hospital, I feel like the conversation used to come anytime we had payment issues. In essence, what I mean is that when hospitals would detect for payments, then the pushback would be, but you are corrupt. That was on one side. But that is not to say that fraud was not happening and that fraud is not a real problem. But I would like listeners to understand this, that it is impossible to have one-sided fraud. Any instances of fraud that were experienced under the NHIF, for example, a few months ago, you remember this exposed outpatients who had fake knee replacements, hospitals which were doing extraordinary procedures. There are no patients. I remember there was one very funny case under Afia, where a provider was accused of going to a school with a truckload of bread and sodas. And then they treated in one day 1,500 students and claimed for all those students. So this kind of things. Now, of course, obviously, if this provider was paid that money, it had to be by collusion. Because even you, if you are a claims officer within NHIF, and on one day you're just sitting there and you receive all of a sudden 1,500 claims from one provider and you still approve it, you are in on it. So the issue of fraud is double-sided in the sense that, one, it was conveniently used to push back against a genuine request for payment. Number two, it was an issue that required collaboration by rogue providers and some NHIF staff. In fact, there's even an extra layer there around the model of capitation. Capitation is the model NHIF has been using to pay for outpatient services, where beneficiaries would select hospitals. And I know a lot of Kenyans did not know this, but this is what used to happen. As long as you are paying for NHIF, for you to access outpatient care, you could select a hospital. And then that hospital would be capitated, rather paid a fixed amount of money per month per head to take care of you. It wasn't much. It has never been much, but the argument has been the numbers game. But I want to tell you an interesting corruption that used to happen there. We are aware that ghost hospitals would be created in the system. And then those ghost hospitals would be populated with patients because of course, it's a computer issue. You could move people from one place. Just before the capitation is paid, maybe even 20,000 people are moved to this quote-unquote ghost hospital. The ghost hospital account is paid, and then those 20,000 people are returned. So the hospital doesn't exist, but the money moves. So these kind of things used to happen, and in the public domain, they are in Auditor General reports. That used to happen. I should mention, though, what will shock our listeners is that when you look globally at what you call claims under investigation from all hospitals, so that we don't unnecessarily paint this problem as it has been made like it's very humongous. It was not. It wasn't humongous as a thing, because in terms of claims under investigation, only about 3 to 4% of NHIF claims ended up queried as fraud. So even if you remember the recent case of those fake surgeries that were being conducted, the total amount that was in question was about 174 million shillings only. That is peanuts compared to the fact that NHIF was at 80 billion per year parastatal. So if you're talking about just 174 million, that is the money some hospitals make every month from NHIF. So the problem of fraud needs to be contextualized. There was fraud, yes, but the fraud that was more dangerous is a fraud that never made it to the media.
That's heavy. I'll come to you, Brian, in a few. Let me give Tracy a chance to also give us some comments, especially on the structure of NHIF and what's weaknesses they had in the system that SHIF looks to cure. Tracy?
As far as trying to improve on the efficiencies of the fund, some of the areas that were looked into that were found to be a bit suboptimal, that required to be optimized, included the areas of functions. In terms of the separation of functions, was noted to have been something that needed to be done to make sure that the purchaser or the fund is not performing functions that may be conflicting. And that is why in the new structure, the law envisions that we have that separation of functions. And here, mainly looking at the accreditation, the empanelment and contracting of facilities. Now we know that that has since been done in terms of being captured by the legislative framework, where we're looking at how accreditation being done by an entire different entity. That is currently it's KMPDC, while after accreditation, that is when now the authority is supposed to use the information that has been provided by the regulator to now empanel and contract providers from whom then the authority can purchase services from. And that is a big milestone in terms of separating those functions to be able to provide more transparency as well as efficiency gains. And I think going down to the operations level, I think Dr. Brand has already talked about that, so I will not go there. But the other broader area of looking at efficiencies and transparency optimization is looking at having purchasing function that is explicit, where we want to make sure that Kenyans, the providers, everybody is aware of what is being provided in terms of benefits. And that is a great move in terms of making sure that the benefits are available and are accessible to the public, so that we are all aware in terms of what needs to be purchased. In addition to what needs to be purchased, is very clear in terms of what level of care provides what services or what benefits. So even as a Kenyan, I'm seeking a service in a dispensary, I'm able to look and see what service am I entitled to at that particular facility, and if it's not available, where am I supposed to get it, and what is the mechanism. In addition to the services, there are the tariffs that have also been made very explicit, which we didn't have before. And that is also very important as far as that area is concerned, because when we know the tariff, then we are able to tell if we have exhausted our benefits or not, or where a provider may require to ask for an extra payment, that it is known it's on top of what. So that publishing and making available of the benefits and tariffs is a big gain for the Kenyan people. In terms of digitization of the systems, we know that now we're moving into, or rather the world is moving to the digital era, and we know the benefits that come with digitizing our systems to make sure that there is visibility of information and data as to what the institution is doing. And that is very important, because then we're able to have access to that information, whether it's a provider or it's the fund itself or the authority, data for patients is available. All this meant of digitization, of course, we know it brings efficiency into the management of the institution, as well as help with reducing the cost of care, where we use the same systems to provide things like telemedicine and all that. That element of improving or investing in digitization is very critical.
I just want to ask you, Tracy, because a lot of the professionals that we deal with, especially in finance, they still themselves are spending a lot of time with SHIF. They're not able to really break it down for the common mwananchi to understand what exactly is SHIF. Give it an elevator pitch. What exactly is SHIF to a common mwananchi?
I would probably start with SHA, because SHA is the umbrella, that's a social health authority that has SHIF as one of the funds. In a common or in an easy language, we're looking at a purchaser who is purchasing the health services on behalf of the Kenyan people, because in the health service delivery, in the health financing matrix, then we have a financial or the source of the funds. Then we do have where you want to now pull those resources from different sources. You want to pull them together so that you have the gains of putting the monies together as well as the risks that are involved. And then after you have pulled the resources, you allocate the resources and do what we call the strategic purchasing. So basically, SHA, that is what its mandate is, to pool resources and to strategically purchase health services for the Kenyan people. And what that means is that if it's the government puts in the money there, it's as the Kenyan people, we contribute, we put our money there in SHIF. So we pay in advance, the government puts the money there, so that now the SHA is able to manage those resources and contract the provider of the services, so that now when a Kenyan person wants to seek a service, when I'm sick, that is not the time now I'm thinking about, oh, how much money do I need? Where do I get the money from? Do I have enough to go to this hospital or that? Will this service be covered? So that is arranged way in advance, so that when someone is unwell or needs health services, then they can go to seek care in a way that is already arranged in advance. So you have those benefits, you know what levels of services or which facilities are you able to access the services from. If it is a facility, since there are many and there are different kinds and different levels, it also helps to spell out the referral strategy. So it says you need a basic service, this primary healthcare service, it shall be sought from. For 2 and 3, that is health centers, dispensaries, and other private providers who are in that level. Then now it spells out that if there is a need for seeking service from a bigger facility, the referral facility, then it is also guiding that the person is going to be referred from a primary healthcare facility to an upper level facility based on what financing mechanism. And that is why it's very important, because now we know that in level 2 and 3 facilities, because it is government funded, then we know we're able to seek the initial service without having to pay. Whether we have contributed to SHIF or not, we're able to seek service from a level 2 and 3, that is a health center and a dispensary and other facilities that are contracted to provide those primary healthcare services. Then that, of course, makes sure that all Kenyans are protected and secured, because then they just need to be registered to seek those services. If a person has now a condition that may not be entirely or satisfactorily be treated in that level 2 or 3 for whatever reason, then that patient now is referred to a referral facility, whether it's a sub-county or a county referral facility. And when they are referred, then it spells out the fact that now that level of care, you need to have contributed to SHIF to be able to access those services. So when the patient is referred, then they are advised you need to be not just registered, but now paid up to be able to access the services at the next level of care. In addition to that, now with the fund, the third fund, the Emergency Chronic and Critical Illness Fund, the Kenyan people, there is now an added benefit that when a person has a condition that is an emergency as described by the authority, then the person doesn't have to have contributed to SHIF to access that service, which again is a benefit, because that means that we can save lives and we can reduce disability that comes from delayed management of emergency conditions. So that is now another benefit because it is funded by the government through the exchequer. Also, we know that previously there are these conditions where even if a person is covered, or rather they have paid up to SHIF, we know there are some conditions that require more money than others. And those conditions are mainly like cancer, advanced cancers that require a lot of treatment or complex treatment modalities. We have conditions like transplants, maybe like a patient who may need a transplanting of their kidneys. We know that those conditions, they tend to exhaust the amount of money that is covered by the insurance, in this case under SHIF. And because they are costly, if all the services were loaded into SHIF, then it would become too expensive for people to be able to afford the premiums. So that fund tries to now take care of those extra charges that usually make people even sometimes to sell their property or to have to seek services outside the country, and they're not available and they're expensive. It leads to poverty because it's catastrophic expenditure, where now the person is spending so much more than 10% of their income towards healthcare. So that fund now shields patients so that once somebody has exhausted that SHIF, they can also be able to or get extra services from that fund through the government, where all they need to do is to be registered paid up members who have exhausted their SHIF.
At this point, also, it's good to tell the audience that if you have questions on SHIF and SHA and NHIF, just below our pinned tweet, you can just write your questions. I'll switch to Brian a little bit. Brian, maybe you can give us a bit of perspective. If I'm walking to a hospital to take advantage of SHIF and I'm a paid up member, how are you supposed to get access to service as compared to when NHIF was in place, practically speaking, from your healthcare provider perspective also?
Quite a number of the patient journey aspects have not been tested in the field. And as you can tell from what we have seen in the news and what patients are reporting from all over the country, there is still a lot that needs to be worked out. So the patient journey is not yet very clear.
On that note, I was wondering, because I've seen a lot of people saying, I went to the hospital, especially for dialysis, and I was not able to access those services. Like, there's a lot of niggling issues in the transition period, especially these are like 3-4 days in. So could you speak to that from a healthcare perspective on what you've seen yourself on the ground in terms of patients also come to you? So as you answered the previous question, you can also answer that.
Okay, yeah, I will try and combine those two questions. So the issue I was talking about is a lot of aspects of the practical implementation of the patient journey. What I mean by the patient journey is that when you arrive at a hospital, your registration, your identification as a beneficiary, what is the system that we are using to identify you? What is it? Is it a biometric system? Is it a card? And what is the portal that contains your data that we can use to verify that you are who you are? Those kind of aspects that go all the way to what is the care that you are due for. You know, what we talk about, the benefit packages being available in an online portal somewhere that are matched to the person standing before me. Those kind of aspects are still very much in flux right now. And that alone explains quite a bit of the problems and challenges we have seen. As we speak, tonight, the SHA portal itself, the provider portal, is not live. And as a matter of fact, as at this morning, we reverted back to what is called the HICS, the HICS platform, which was the NHIF platform that we were using. It now has basically a SHA logo there, but it is still the NHIF platform. And providers now are logging into that platform using their HICS, which are really NHIF credentials. Now, in the time lag between us figuring out that the SHA portal is not ready and us reverting back to the HICS portal, in that time, there was a lot of hue and cry around the country because essentially, as I've said, providers had no way of verifying that this person before me is who they say they are and this is their benefit package as per SHA. Now, that would have explained also issues around pre-authorization because that also was not possible. And that is one explanation. The other explanation just goes to do with uncertainty in terms of the future. Let me explain that. As at today, forget what everybody else is telling you, but a vast majority of providers, whether government, faith-based, or private sector, are yet to sign their contracts. And my understanding is that is for two reasons. One, nobody had read the contract before 2 days ago, despite us asking for it. So you can imagine if a binding contract for the next 2 years lands on your desk and you are supposed to return it within 12 hours, obviously there will be jitters. So there have been jitters around that, but there are also just logistical challenges. Initially, we had been told that there would be electronic contracting. In other words, a link would have been provided and providers would just go in and submit, click a button, and that is done. But it looks like that also was not ready in time. So again, there was time lost in revert to plan B. And plan B now had two components. Initially, plan B was, and what has happened before is hard copies of the contracts are sent to NHIF, let's call them SHIF branches now countrywide. And then providers are usually told go and pick your copies from your branch and you go and pick, sign and return. Now, imagine trying to do that for 12,000 facilities within a day. It's a literally mission impossible. So we switched from the hard copy. A few providers got hard copy, but then it quickly became clear that branches, NHIF branches, don't have enough reams of paper to process this, because we were talking about one contract that is 83 pages and it's supposed to be printed in triplicate. So you can imagine, just multiplied by 12,000, it's mind-boggling. So that also failed, and then we moved to the request that can providers print these things for themselves, sign and return? Of course, now that also generates a problem, because some of these very rural farmland areas, who gets a good photocopier or printer that can run 249 pages fast enough, bind it? So all that is the picture I'm trying to paint as to what has been happening behind the chaos that we have experienced. The fact that providers also are asking, so who's going to pay me? Fine, I'm going to treat this patient here. This patient requires dialysis, but my contract with NHIF ended on 30th of September. I do not have, even if you say liabilities were transferred, but I don't have a SHA contract. So we are in this lacuna period, this period of uncertainty. And you saw a lot of providers say, okay, we are not going to take the risk of losing, or just that these claims will not be paid. Nobody is going to have visibility of these claims because there is no portal, just pay cash. And that is what was part of the problem that created this uproar that you have seen. I don't know whether that helps.
But it just paints a picture of a rush way of implementing a system that is new, that even the healthcare providers themselves did not have visibility about contracts and about something as simple. The patient journey has not been. You need to have perhaps, how you call it, like a 5-step journey. When you go to the healthcare provider, this and this and this is what you expect, and this is what you expect, and
absolutely
the end. So I think that was missing, because I've not seen anything like that yet myself.
Absolutely. And those could be a simple flyer that could be digital, also spread around on digital platforms. Also, even we could have put that on TV, explained it on radio. This is what you are going to expect from 1st of October. When you go to your hospital, this is how you will be verified. And I've not even mentioned, even when the SHA portal finally gets online, providers have to be trained on how to navigate the SHA portal. This is yet to happen in any meaningful way. So we are rushing. The only thing that gives me hope is people say, Mwai Kibaki woke up one day and declared pre-primary education. And for a couple of months, there was a hue and cry, but eventually now free primary education is the standard, the sine qua non, the standard in Kenya. So maybe that's what gives me hope. But unfortunately, here it's not free primary education. Here lives are at stake. So we are in a situation where I feel for my colleagues, the people who are working at SHA right now, trying to figure this out, must be horrendously difficult work. But as a healthcare provider representative, I still strongly believe that we did not have to land ourselves in this place with this level of unpreparedness. This was not supposed to happen. Remember, the president signed into law these changes about a year ago. We've had a year to prepare and figure out what we're going to do. But unfortunately, it seems that we missed the boat. I really just hope that we can correct. As providers, we have been cooperating. We are trying our best because we really want this to work. We really want it to work for our patients. But I think we have had quite a significant challenge on execution.
Tracy, I wanted to come back to you about some of the benefits that you highlighted. Someone is saying that they've looked at some of the benefits and the limits that you have, and people are not protected from fundraisers as perhaps you stated there. Is that true? Or what could be the issue here in terms of the limits that they've put in place already for SHIF?
In terms of benefits, as That's it. Overall speaking, when you look at it from that perspective of getting a full spectrum of care, from primary health care to secondary and tertiary care, with elements that are covered entirely by the government, which were not there before, that is quite evident that we do have added benefits. Also, now when you look at the services maybe under SHIF, the reason why we might be getting this kind of feeling or observations is because, or could be because, under NHIF, we did have different schemes. And I think we've already gone through the fact that we needed to have a harmonized scheme to be able to get better value for money for the Kenyan people. If you look at what NHIF was providing under the national scheme, what the populations, those who were paying 500 shillings per month were getting, when you compare that package with this package now, this package is definitely much, much better. But where the issue could be, maybe somebody is comparing an enhanced scheme that used to be provided by NHIF with this particular package, which now the enhancement is not what we are looking at. We are looking at the social health insurance aspect under Social Health Authority. And that's why we say that some of those benefits that people may have been accessing under enhanced schemes were removed from the SHA benefits, because that is now something totally different from the principle of social health insurance, where we want to expand the services, provide more benefits to all Kenyans so that all of us have these benefits that we are entitled to that are similar and are beneficial to all of us. Then if somebody would like to have something bigger to complement that or to supplement that, then those are now arrangements outside of the social health scheme or the social health authority benefits, and they're not prohibited if an employer or any individuals would decide to have added benefits from other arrangements in addition to the social health authority benefits, then that is also allowed to complement what Social Health Authority will be providing. That said, for sure, if you look at the benefits for the national scheme that NHIF provided and what we have here, it is rather obvious that things like emergency services were not provided for. We didn't have that before. And now a patient can walk into any facility and receive those emergency services at no cost, even without having been a contributing member. And that was something that was totally out of reach for a Kenyan individual. Even when you look at other services like post-transplant treatment, this is a medication that patients are put on after undergoing, let's say, a kidney transplant to sustain that kidney and to keep them in a healthy state. Because those medications are costly, they were not covered before, but now they're provided. And this is something very good, because then we're trying to encourage and to promote the shift from somebody having to undergo dialysis throughout when they have an option of getting a transplant, because most people would then continue on dialysis because it was covered. Their post-transplant cost was not covered. So that's also another quite a significant gain as far as these benefits are concerned. When we look at even something like Linda Mama, now when you look at the reimbursement rates that will be provided for a normal delivery, a cesarean section, compared with what was being provided, then the increase is quite obvious. We have almost a 3 times increment in those tariffs. And that is something very good, because then that means that a mother can deliver without having to be asked to bring in other inputs or to add more money. When you look at conditions, what we call mainly the chronic conditions, these are diseases that someone requires care for a long period of time in their life, prioritizing on things like diabetes, hypertension, sickle cell, asthma, and other obstructive airway diseases. Those ones have been introduced in terms of when the patient is on follow-up, their investigations, or rather the tests that they need to do when they are visiting the health facility for follow-up, they are covered. And we didn't have that before at all. So that is also something that would ease out on that expenditure for that patient that unfortunately has that chronic condition and they have to visit a facility from time to time. Again, when we look at the reimbursements for inpatient care, you see an obvious increase in terms of the amount of money that SHA will be paying to the facility a day when the patient is admitted. That has been increased and also has been harmonized across facilities, whether it is a private or faith-based or a government facility. And that is something that is clear. And even when we look at other services like surgeries, again, the rates have also been adjusted significantly. And then also the scope of the surgeries that were available to a patient under the national scheme under NHIF and what is available now, we can see that we have more. The same with things like cancer care in terms of the full scope, where we're looking at from the point of diagnosis to the point of treatment, follow-up. This package has looked now at the spectrum, the full continuum of care, where we're looking at even from screening, the point of screening, where when patients go to the facilities, what we want to do is to, even before somebody says, I am unwell or I'm feeling unwell, we screen, we look for, do they have any signs of any of these conditions so that we can be able to pick early. Those kind of services were not there before. And for patients who may require what we call the palliative services, and this is services that are provided to somebody who may be having a life-threatening condition or a chronic condition that requires extra care. Those services, again, we didn't have them covered. We brought them in. Other areas that were highlighted were also to do with like assistive devices for patients who may be having any form of disability or requires a form of support in terms of a device. Those ones we also didn't have them, and they are also covered. So I will not belabor the whole benefits, but you look at them, you can see there's an obvious increase and an obvious benefit to that Kenyan person who, when they were paying 500, had very limited benefits, and now they are much, much bigger, they are broader, and the fact that some of the benefits they are accessed without having even to contribute because the government comes out and provides resources for that. So I really would still say that it is an improvement, a significant improvement moving forward.
You've talked about the benefits, but then in terms of funding, where does SHIF and SHA get money from? This is day 3 of SHIF. They still not yet received money. The contributions, I think, are supposed to start at the end of this month. Then where does SHIF get money from, per se?
In terms of funding, the advantage of this kind of model where we're using prepaid mechanisms and the contracting methods is that the cycle is such that a patient seeks care. When they seek care, the facility places a claim. When the facility places a claim to the Social Health Authority, then the Social Health Authority periodically pays those claims that are being launched. So what that means is that today I may seek a service. The Social Health Authority may not have received the money, but because the money is already worked out and is known where the money is coming from, then patients are provided with the services. And by the time the claims are coming to the Social Health Authority, then the resources have already been received and are ready to be disbursed to the providers. So that cycle helps to make sure that the service can always be accessed.
And then it's the employed and unemployed. How do you get money from them? What's the plan here?
As far as the contribution of the financing is concerned, that is the health insurance bit. Yes, we have two distinct populations. That is the formal sector, those who are on payroll somewhere, and the informal sector who are self-employed. And also we do have those who might not be able to pay at all. The arrangement that we have is that those who are employed, of course, then it's a statutory deduction, the source through the employer. And then for those who are in the informal sector, once they are registered and then they're informed of how much money they need to pay, which we said, of course, we want to use a progressive method, which is based on how much income we have, then that is the amount of money that they will be required to pay to SHA.
How do you assess that, especially for the informal workers? How do you assess practically? How would that be assessed?
The assessment of how much the informal sector person should pay, what has been envisioned is that a tool, which is called the Proxy, the means testing tool is utilized, which is able to determine what kind of income the individual has, and from that then it's able to compute for that particular income the 2.75, then how much do they need to pay. So all that is done by the tool, and the person gets to know how much ideally they should pay.
And is this like an annual payment, means changes over a period of time? We will be assessing this often, or is it a one-time assessment? And what if they don't pay them?
principle speaking, we know that incomes are dynamic, not just for the informal sector, but even for the formal sector. So in terms of SHIF contribution, then share has to get regular updates as far as the income status of an individual is concerned or a household, because even for those who are employed, somebody may lose their job or they may change their job or they may get a rise. So all those factors, since they're dynamic, then it means that data has to be updated regularly for both sectors.
I'm just wondering about the Juakali person. Like, how will he be assessed? What are you looking at? If today, as maybe someone in the informal sector, practically, how would they be assessed? What tools are you using to assess this person's income to be able to know, okay, this is what you need to pay and this is when you should pay it?
Basically, as a rule, when people want to assess the income status, an informal sector or an individual for whatever reason, there are different documented variables that are utilized, which help to assess the expenditure, because it is known that what people are spending or their expenditure are related to their income. So then using different variables that are already documented and used, then that tool, that is what it does. So you get a number of questions which are predetermined, and then the person answers the questions and the tool is able to compute that level of income and hence the deduction rate, or rather the payment rate. That said, we know that it is something that requires to be approached with a lot of caution, just to make sure that we don't have a situation where people may feel disadvantaged or the information that is provided is not accurate for whatever reason. So I believe now that we're in the rollout, then that will be approached and addressed accordingly as the situation evolves.
Tool for informal sector assessment being tested in a way just to check if the assessment is appropriate? Because if you're relying like on questionnaire, people have been known to lie on these questionnaires in terms of assessment and also to pay lower. So it's a bit of a mystery, to be honest, on how this is supposed to work. Do you agree with me?
Definitely, we do recognize that the objectivity of the tool may not be as high as, say, someone who is on a payroll where the payslip indicates this is the amount of income, because now this you have to assess first. That means that it is a more rigorous exercise. And what that means is that we all know about all those factors that are likely to influence the objectivity or the accuracy of the results that we get. And therefore, that is why it's very important that a lot of considerations are made to make sure that we get the best out of it, and we don't have people who may be asked to pay more than they ought to pay or less than that they need to pay. But that said, I think you've also said the idea of people giving information that may not be accurate. All those now are facts that reduce the objectivity, and that is why a lot of work has been put into that, as well as even piloting. A lot of piloting has been done in different areas of the country. So where it was piloted just to see on the ground what the tool brings out and what is actually on the ground, where the questions are asked and then the households are assessed in real time to see whether they are matching. And that has been done, and all that data is available. And that's why I said at this point in time, I'm sure as the situation unfolds, then our decisions will be made accordingly so that we have a clear and a satisfactory way forward. If any challenges arise, then people see the challenges and then people deliberate on those challenges and find what is the best way forward, depending on what comes out of it.
Very interesting. I would want to drill down a bit more, but let me go to Brian because he also has a couple of points to add on this. Brian, over to you.
I just saw that we balance this out. Number one of the things that is obviously clear and a reason for the vigorous debate is that the money available to pay for the benefits is not enough. Even if we tax at 2.75, we don't think we will raise enough money to pay for the healthcare that Kenyans want. So once we understand that reality, a very important thing for us to do is to be very careful on what we tell Kenyans is possible. I'll give you an example that it's true, as my colleague has said, that quite a number of benefits are new. For example, the screening benefits are new. The laboratory package is new, but some of them are also fairly old, like the surgical package, etc. one of the things that we in the sector know is that any increase that we have right now has just barely caught up with inflation. It's just barely caught up with inflation. So yes, you flip a page and you say, this figure on the last NHIF contracts was 40. Now it is 45. Is that an increase? From a layman's perspective, it's obviously an increase. But if you are in the sector, it is an increase too late. The cost of inputs between 2021 and 2024, when the last time the prices were adjusted, the cost of inputs has changed. Inflation has eaten away much of that. As a matter of fact, as sector, we have already been asking for these prices to be adjusted long before the Social Health Authority came along. So we really do need to be careful, because I feel that if we message to Kenyans that hospitals are being paid a lot of money now, what is going to happen is that when a Kenyan walks to a hospital and they encounter a request for co-payment, Kenyans are going to be again lied to by their government. And a lot of the issues we have with the NHIF are a lot of what is it called, the baggage that Kenyans are carrying is feeling like the social contract was not kept. And I think it's important for us to say that, yes, what we have is a beginning. It is not perfect. It is probably the best we have done is try to catch up with inflation, but we are still not where we need to be. Patients can expect that they will experience co-payment. That will happen, because I can tell you there isn't enough money in the sector to provide that care. That's just a point I wanted to make on benefits. On the issue of the informal sector, just listening to Dr. Tracy, you can see that there are really a lot of challenges around how do we target the informal sector. As I started by saying in my earlier remarks, the biggest problem with the NHIF was that the informal sector was not playing its part. And almost everyone on this call knows that there are people who don't have a payslip, but they make much more money than people who have a payslip. And yet, during the NHIF era, that person would only have paid 500 bob to get care, and yet probably earned a lot more money than somebody who has a salary. What our opinion has been as facilities is that proxy means testing. This idea that you have a set of 17 variables, 18 variables that you use to determine as a proxy for household income. Basically, what this proxy means does is that it uses your consumption as a surrogate for your income, because the argument is that you cannot consume what you don't earn. But it is worldwide, and we have said this, I just wanted to say this so that for the sake of balance and some of the things that we think need to be changed. We can start right now, but I know they will need to be changed. For example, if somebody walked into your home and said, since you have a microwave, you should pay more contributions. What if the microwave was a wedding gift? Or let's take the elderly, for instance. A lot of our parents who are retired, you can go to my mom's home and you will find a refrigerator. Does that mean that she's wealthy? Proxy means testing might define her as wealthy, and yet it is us, her children, who have the refrigerator there. You take it even to border guys. Having a border would place you in lower middle income because you can afford a motorbike. But if you talk to the border guys, there will be a problem. So proxy makes testing, our argument was that it has not worked anywhere worldwide and it over-targets the poor. What I mean by that is that the many papers that show that wherever proxy means has been utilized, it has enormous exclusion errors. And what I mean by exclusion errors is that it excludes people who are poor and declares them rich, because the proxy means testing tool is designed to limit the contribution of government to social welfare. So it over-excludes people so that government eventually has less and less burden. I think this is where we are now. But if you ask me, I think that we will have to reform that idea of proxy means testing. If at all we are going to be able to target the informal sector, we will need to expand that tax bracket that Terry was talking about, that tax bracket which is funding primary care and that tax bracket which is funding chronic and emergency illnesses. That is the only way we can go. General taxation, what we call consumption tax, is much more simple, much fair, and it brings on everybody. The reason why they didn't go for general taxation, as far as I know, is because the argument was general taxation targets the poor unfairly. What I mean is this: they argued that a person who earns 10,000 would spend more of the 10,000, like they will need 9,000 shillings in a month, which is 90% of their income, just to get by. And if they are consuming that and you're taxing that, so you're taxing more of their income. But somebody earning 100,000 can comfortably, let's say, live on 20,000. Therefore, 80,000, they are sparing a lot more of their income. So they said consumption tax is regressive. But can I tell you that even if consumption tax is regressive because it targets the low income earners who consume more of their income, when you collect the taxes and you protect them through consumption tax, and you use those taxes for the right purpose, the people who benefit the most are the poor. So that is where we should be thinking as a country. I think we were a bit scared. We still suffered the Mwai Kibaki problem of fear. And unfortunately, it's bringing us to this situation.
Dr. Tracy talked about you had done a pilot project in some counties and stuff like that. I looked at the sample. It's 2,000 Kenyans, though. Is that really robust enough to make a decision on an entire system like SHIF?
I think as far as the income determination, or rather the amount of contributions for the informal sector is concerned, I think we've at least up to now, because a lot of this work is in progress. You do something, you come up with something, you put in the best information available, you work with the information that you have, you move forward, you gather more information, and you keep reviewing until you have something that is optimally functioning, or that is providing the highest level of benefits, as it were. So what that means is that when we're looking at this model, or this approach, or this tool, or any other area that may be having challenges, it means that people get to see, what does it bring? When you pilot what you have, then you improve on it, then you take it out again. And I would say, just like I said earlier, that at this point in time, we are going to see what the players are involved will decide based on the information that comes out.
Dr. Tracy, maybe a bit of a rejoinder. This is an entire system that affects the entire population of the country, 50 million plus people. Isn't it the best practice to at least test it in a bigger sample, quite enough sample, make sure it's robust enough, and then scale that up to an entire country? Because when you put a some deadline of 1st October, the system is not ready. You were very clear on that, like in July, when it was being postponed for the start date, it was clear that the system wasn't ready. The healthcare providers here, including Dr. Brian here, saying, hey, we don't even know how the patient journey is supposed to look like. I look like a bit of a new system that should be in place before we switch. That's the thing that I'm wondering about.
What I would say is that in terms of the area of the SHIF, I think it's important that we're able to separate the areas that are moving on well and the ones that may be having some challenges that need to be addressed, because we can't say everything is all working when a good number of things are working. And hence, then we become objectives, and we put now our minds into where the challenges are to be able to address those challenges to help us get moving and getting better. Because some of those areas, you will not know how it will turn out until it's done. That doesn't mean that the implementation is not well informed. A lot of work has gone into it, and a lot of gathering of information to inform the decisions that have been made. That has been done quite rigorously. In terms of the SHIF element, that is a contributory bit, that challenge of which way to go, because these are already documented methods of raising resources for the health insurance. Do you go contributory, where the members contribute, both formal and informal? Or do you combine contributory and taxes? All these are methods that are already known and that are utilized. So it is about looking at the information and the situation that we are confronted with at the moment, making the decision, and probably gathering more data to see how to move. So in terms of the means testing for the informal sector, it's just about looking at it from, do you go contributory or do you go non-contributory? So then you look at the non-contributory method, then it also has its own challenges. So then it's not a thing of, I have something so much better and I didn't go for it. It is a situation where you have two elements that you need to choose from, and both have their own strengths and weaknesses. And here now you have to weigh in and make sure that you're walking that journey informed, so that whichever challenges you face, then you know why you're facing them and how to address them. The other side of using the taxes also has challenges. So it's not like there is something that is 100% that has been left out as far as pooling the resources for the health insurance are concerned. So I would still insist that the challenges aren't as they are experienced, then they will be looked into, and all the players will deliberate and see what is the best way in terms of moving forward as that source of income or source of resources is concerned. That is the informal sector, how to get through those resources, because there are many other ways that can also be tried, but we move one step at a time.
The comments I'm getting is that the government is a bit too optimistic about the targets in terms of what they can raise. And I think when I talk to Brian here, he's saying really that there's not enough money in the system to be able to fund some of the benefits that you are stating out there. So I don't know. I would want there to be a good healthcare system, but then again, it seems like SHIF has a lot of niggling issues that need to be dealt with. Dr. Tim is here. Dr. Tim, did you have some general comments that you wanted to make before I switch to Dr. Brian here?
Hello, everyone. My name is Theuri from Kenya Healthcare Federation. Present the private sector in the healthcare space, spanning the entire value chain. And providers generally tend to be the customer-facing side of healthcare. Brian and Rufa, through Rufa, our members. And we've been on this journey for a while. But rather, there are a number of good things that are coming out of this. And one is for providers is separation of function. That was a pain, like Brian mentioned. Two, the claims adjudication process. That is from when a claim is entered into the system, the journey that it travels. There has been promise for transparency in that, and technology is being leveraged to bring this out. Third is that money that is collected by the Social Health Authority cannot be invested. It cannot even be in an interest-earning account, which is a good thing. Because there's no incentive to keep the money. So I think every so often the money is swept into provider accounts. That brings me to the pain point, I think, in the industry. And I will be very dispassionate and hopefully pragmatic at how I look at it. And that is, we must begin to look at how we are running our various sectors in the country as businesses. Health is not immune to the happenings of business. And we must look at it like that. It is a social good and possibly the only one we haven't sorted out as a country for our citizens. And when I say we look at it as a business, it's to rationalize how much do we have and what do we have and where can it go. SHA is not equivalent to UHC. It is one of the vehicles that will deliver UHC for us. And if SHA was to work as envisioned on paper and other things like even commodity security are not taken care of, then we'll end up with a situation where we have affordable care that is unavailable. As we speak, providers are owed quite tidy sum. I think now that's north of 30 billion. And because I said we look at it as a business, even for the county governments who are delivering bulk of the care for the public sector, it means that we must take care of our input and output. And SHA is one of those mechanisms, and it is offering a fixed fee for service, meaning that what will be coming in after service has been provided is known, but what will be consumed while providing those services is as variable as possibly fluctuations in Forex. My hope would have been some flexibility in the rollout phase as opposed to tying down 2-year contracts so that we see how performance will be. And tied to that would be a lot of fairness in the system. 1, in service delivery, 2, in contributions, and 3, and most importantly, in operations. Any decent healthcare system seeks to do one thing, and that is to optimize the relationship between the person who is seeking care and the clinician, the doctor, if I may use that word. And the mwananchi at the point of service care or when they're seeking care, honestly does not care about the high-end conversations we do have in boardrooms as policymakers. Them, they want to come, be attended, live with medication, get their operations if they are surgical patient, and get better. That's what they want. How we make that happen now are the conversations that are our 8 to 5. And when it comes to fairness in service delivery, I think there have been some improvements, but what I'm really keen on is the question of where does catastrophic expenditure happen? Is it at the higher level facilities or is it at the lower level facilities? And my analysis has been, it's contributory. At the higher level facilities, it's where complicated care is sought, and it is often late, meaning that our suspicion index at the lower levels needs to be improved. And that brings me to an important conversation that we must think about as Kenyans. With SHA, how are we incentivizing the system to behave? Because that's the most important thing. When Linda Mama came, it was a fantastic product. We were able to get care to many of our mothers, but a very silent thing happened. We changed how the system was incentivized. And that was because of the low margins, providers focused on just being safe and business continuity, even for public facilities. And we ended up having a patient turnover as the metrics that was looked at as opposed to patient outcomes. So that is a question I'd really like to leave us with here. How will we have changed how we incentivize the system to behave? Because that is the most important thing in any change. As I close in the interest of time, and I think it's conversations Brian and I have had sleepless nights about, is we're in a season of change, and to our colleagues at SHA, and I do not envy them in this season because of the task at hand, is let us communicate this change very well. The provider network is a fantastic army that we can use to communicate the changes that we seek to bring. Our healthcare workers are a fantastic army as well. Let us utilize them when communicating the changes, because I have had a very sad 2 days, because any one life lost in the process of transition is a needless loss. And the reason I say that is because I would dare say there's no urgency given between getting it right and on time. I'd always choose getting it right, but we had to roll out. But be that as it may, we should really take care of that one life that is desperate for care, much as we're implementing change, so that we do not lose anyone in this process. Because unlike any other sector, our mistakes or our mishaps, they don't end up in jail, they end up in a grave. And that is a very sobering thought that I always have at the back of my mind. KRA has been assigned as a collector, and I think, or I hope, that we could have a conversation of how we net off for providers the debts that are owed for county hospitals and also the private sector players. Because the more liquidity we have in the sector, the better for everyone, because it means that we're able to improve on our systems, we're able to pay our workers, and we're able to generally improve the quality of care. As it is right now, government is operating in a very restricted physical space, and the people who can build scale are on the other side of the stick. 56% of our care is offered by non-state actors, muted at 46 or 47% for mainstream private sector, and maybe another 8% by faith-based organizations. So we must take care of each other because of those numbers. Finally, as a country, we need a blueprint for health. We can't have the cyclic political changes that we see in the health sector, because on average, it takes about 15 years for you to realize any turn on investment in any change that you bring into the sector. And we must quarantine the sector from the political happenings. And a blueprint is the only way that change this. And we will use how much of acreage maybe a president, a governor, or your MP is able to cover in that blueprint as the indicators for success. So if your governor is able to move you from point A to B in that blueprint faster, then we'll manage to say that this is a successful leader. If not, then in the next election cycle, we're able to have the conversation of, do we change, or what were the precipitating factors that did not bring us success? In that way, we will bring the one thing that I think every Kenyan would want, and that is a Kenyan that wants better because they know better. Thank you.
Thank you, Dr. T. Quite a lot of concerns you've raised, very valid ones. In the interest of time, you have 17 minutes in which I want us to conclude. I wanted Tracy to respond to a few questions here. So there was one asking about today's Nation had the front page of the SHIF nightmare in terms of the transitioning period, the way it's been very painful for a lot of patients and all. What have you guys at the Ministry of Health received as feedback from the ground in terms of how SHIF is working so far? And then a question from Barbara, maybe this is a question to you also and to Brian. Have you visited the poor neighborhoods and rural areas and seen how perhaps SHIF is affecting them so far? Let's start with Dr. Tracy.
Thank you very much for that question. Indeed, we're all aware that having rolled out on the 1st, we know that a good number of things have gone as planned in the right direction, and we have a few areas that may have experienced a hiccup. And having been assessed, of course, people have since looked at most of those areas that were experiencing challenges and looked at how to have them sorted out so that we keep improving as we move along. And it's unfortunate that some people did experience very bad situations, but all this has been recorded and reported, and people are really looking into how that can be sorted out. And I'm sure even those who may have experienced some challenges have seen that some things have already been fixed. Others may still be in the pipeline. And I do believe that we will be able to fix remaining issues.
Dr. Brian?
So this is one of the things I go through every day since over the last 48 hours. What I can tell you is that, and I think I explained this by saying that we are here, we could have done a lot of things better. We could have been prepared, and I have given the circumstances under that. But I do need to tell our listeners that it would be really unfair to pin any suffering out there to SHIF. This is a brand new baby. And we may have argued about how we got here or how we are going to implement this. But certainly this particular point has nothing to do with SHIF. I think that we will need to have a couple of months under our belt before we can certainly now critique SHIF properly if there is need to, and praise it. The only thing now we are doing is talking about design problems. We are saying this should have been designed this way. This one should have been designed that way. This room should have been painted green. That's what we are talking about, but we are yet to live in the house. Over the next few months, we are going to move into this house called SHIF and primary healthcare and all this. And now we will start to see whether the plumbing was not done properly, whether the electrical system short circuits. But yes, it is a difficult time right now. And we as Association of Providers, the one thing that I can say is a positive, a big positive, is the access that we have to the decision makers has improved over the years. We have moved away from the time when the leaders used to sit in a citadel and they listened to their few cronies. And this is something I really celebrate about Kenya, the fact that we can have conversations even at the very highest level. And we need to use that access to talk about what is not happening correctly. And I think as an association, the Rural and Urban Private Hospitals Association of Kenya, we are going to play our role without any fear, without any favor, because the Kenyan patient is our concern. The Kenyan healthcare provider, who right now, and I can see quite a number of our people on the call, right now they don't have drugs on their shelves, Eric. Some of them have been paid rent. Some of them, the landlords on their neck, they are auctioneers. And you know why this is the case? I would put the blame more on the historical injustices around NHIF, where we had government agencies, and this has even been admitted by state officers like Principal Secretary, Cabinet Secretary, government agencies to this day, parastatals, the National Treasury, they owe NHIF 30 billion shillings. That is what is making the sector suffer today. Not the transition to SHIF. If today you were to pay the sector that 30 billion, the providers will continue providing care. But I am concerned, I am worried that now we are going to have a deluge of patients, thousands of people now, because we have told them now we are in the era of UHC. And of course, we know how people behave when they have medical cover. You give medical cover, people use it. So we are looking at high numbers of patients coming to the hospital, but hospitals don't have drugs. Hospital employees haven't been paid. Electricity is about to be disconnected. And guess where the problem is? The problem is national treasury, parastatals. You and I, the regular Kenyan, we are going to pay our 2.75%, no problem. Whatever it is, we will pay, because we have no option of not paying. Because you don't pay, penalties will arrive. But who penalizes government? I have looked at the regulations. The regulations say that if as an employer you fail to meet your employees' SHI contribution, you are liable to fine of up to 2 million shillings and up to 3 years imprisonment. Now tell me, which government agency is going to be fined 2 million? We need to see, that is what my hope is, that now that we are in the SHA era, when government agencies don't remit money that they are going to deduct from their employee pay slips 2.75%, a CEO should be in court, somebody should be fined money, but we should never have the situation that we have had over the last 2 years, where 30 billion shillings that is deducted from civil servants' pay slips did not arrive in the kitty, and now we have a health sector system that is struggling. I think that is the picture I need to paint about why you're having all this. And it's not private sector hospitals only. Mission hospitals don't have drugs. Government hospitals don't have drugs. I know there are Kenyans who are going to government hospitals and being told to go buy gloves. Why? Because government hospitals are also owed money. For me, Eric, this is why the situation is bad. It has very little to do with SHA. We haven't yet gotten into that. Right now, you can simply switch and start using the NHIF system, and we will pre-authorize dialysis, no problem. But where is the money to provide that care?
We have to close the conversation for now. So I'll now give you time to give your closing thoughts. Start with Dr. Tim, and then go to Dr. Tracy, and then finish off with Dr. Brian. Dr. Tim, quick thoughts on generally what maybe the listeners should take away from today's conversation.
It's 3 comments. One is a rising tide will rise with all ship at sea. And what Brian has brought out, I don't think we can belabor that picture anymore. And I really hope in your next conversation we have someone from Treasury here, because our colleagues at SHA, it doesn't matter how well-meaning they are or how good a system they have, without Treasury sending money, it is all naught. The second one is we must seek best-in-class healthcare for our people. And the reason I say that is when we are buying cars for our leaders, when we are buying guns that protect them, we don't go for resource limited setting guns and cars. We go for best in class. So for healthcare, we must also go for best in class. The final comment is I really hope out of these conversations that we're having, because of the democratization of health, that we're also going to ensure that our Kenyans know better so that they can want better. Because the Kenyan is a person who is obligated to as leaders. And I say us as leaders because we are the people who are in the healthcare space and are in the rooms that take some of these decisions. So we must want our people to want better. Thank you.
Thank you. Dr. Tracy, closing thoughts on what key takeaways the listener should take from today's conversation.
My last thoughts, I would like to emphasize that I do believe that we are moving in the right direction towards mobilizing enough financial resources for UHC. And this is because we are looking at the mechanisms that are known to work and they will work, because we're not going to reinvent the wheel. We know that health insurance is good for us, all of us. When we put our monies together, we are able to help one another with the resources that we have. We support each other to be able to access the care that we need when we need it and in an affordable manner. Also, in terms of mobilizing resources also from other sources, including government sources, where we're also in the right direction. And I believe that we will be able to progressively mobilize more resources from there so that we can be able to finance those services at the lower levels, that is the primary healthcare services, as well as services to be provided under ECCIF. And this will help us also as Kenyan people to be able to reduce the amount of money that we pay when we seek care at the facility level, and the poverty that comes with sometimes having to give away property because we want to raise money for our healthcare. All this, and knowing that after we put the money together, we are able to get a benefit in terms of the services that are available to us. It is a good move for all of us, and it's a good direction, so that we can be able to create a healthier Kenya. And of course, we know that healthier Kenya means that we have better contribution to economic development and therefore be able to generate more resource for our sector. Thank you very much.
Thanks. Finally, Brian, any concluding thoughts?
Yeah, despite all the comments I might have made about the challenges, I want to ask Kenyans to register. The reason why I think it's important to register for SHA is that we can only make the argument for resources allocation when we have an argument based on the number of people there. One of the pushbacks we have experienced on the issue of funding for primary care, when we asked questions why 4.1 billion, was that it is enough for the people who have registered, and that argument is valid. I think that we do need, especially the Gen Zs, the millennials who feel they are healthy. Why do they need health insurance? I would encourage that generation to take up this. Register, let us make a case. The second and final thought I have is, despite the challenges we have, I honestly think that this could be the best of times. The best of times in this sense that finally it's going to matter that our hospitals don't have drugs. I can imagine there are Kenyans who, because they were paying 1,700 shillings, and yet they earn 500,000 shillings. They would not care because that would not register. But now when that has moved to something like close to 200,000 shillings per annum, I think it's gonna matter. And for me, I hope that at the very minimum, the fact that we are now required to dig deeper into our pockets to finance healthcare is going to make us to be the number one advocates, even as citizens, for our hospitals, for our healthcare system to work. And we are going to shed the nonchalance, the aloofness, and finally start demanding the healthcare we deserve. Thank you.
Thank you so much, team, Brian and Dr. Tracy, all of you for joining us on Spaces today. Really appreciate that you took the time to at least break it down for us, be able to understand what are the key components of SHIF and how it differs from NHIF. And lots of questions have been left unanswered, and would really love if you can have you guys again at some point in the near future to have another discussion about evaluating how SHIF is doing.